Thank you very much. If we could get our panelists up here now, please. Run, don't walk. We're a little behind schedule, so we're going to catch up. I asked the panelists to speak and do just very, very short opening remarks in around 2 minutes. 2 minutes. So let me say this: we will double your speaker's fee if you're under 1. So we are working on it. Now's a good time. If you have questions, please get them up and we'll collect them. Terrific. I see a bunch of questions coming, which helps. When people get settled, I'll do real quick introductions. Brett's being a gentleman. So from your far left toward me, Brett Lawton is the Chief Operating Officer from Jericho Road. Then Cassie Dauphin, Brenda McDuffie from the Buffalo Urban League, Paula Gorman, the Chief Operating Officer from Southgate Medical, Bruce Nesbitt from Spectrum Community Behavioral Services, and Ann Constantine from Horizon Health and Human Services. So I'm not sure what order we want to go in. We could probably just go from Brett working on this way, and then again we can keep them short, and we'll try to keep this real punchy. So get the questions to us, and then after the presentations we'll have some hopefully some rapid fire question and answer. Thanks.
Brett Lawton, Jericho Road Community Health Center. We are a federally qualified health center that serves primarily the city of Buffalo, and our niche is serving the refugee population that have come to reside in Buffalo. And last year we're on course for seeing 18,000 patients this year, up 2,000 from last year. So we continue to add capacity as we can. And we have behavioral health integrated. We have pharmacy services. We're a care management agency with Best Self, Honey, Health Home, so we have some care management activities that way, but that's a brief. I want that speaker's fee. Go for it.
My name is Cassie Dauphin. I am a community health navigator for the National Witness Project and the Witness Project of Western New York. We are a community-based organization that serves the underserved, never-served, uninsured populations. Our mission is to educate, empower our community, and navigate them to preventative services. So we work really hard in connecting with the community. We have our outreach team who are boots on the ground, who are always out canvassing the community at our food pantries, community centers, senior centers. So our mission and our goal is to make sure that the community feels supported and to connect them to resources that are available to them.
Good morning. My name is Brenda McDuffie, and I'm the president and CEO of the Buffalo Urban League. We are a community-based organization that is celebrating 90 years in this community this year, and I'm very blessed to share that we have worked to empower individuals by providing services from birth all the way through senior years to approximately 20,000 individuals that we touch directly in family preservation and support services, education, employment, housing, quality of life issues that impact the entire family and the entire community. And we focus on providing grassroots and grass tops, both at the policy level and at the service level, touching the lives of individuals in our community. And so the community health worker work that we're doing since our inception and really carrying it out now in the community is a large part of that.
I'm Paula Gorman. I'm from Southgate Medical Group. We have a large primary care practice in West Seneca. Mostly we have primary care providers, but we also have a few specialists on site and some ancillary services, physical therapy and some drug research. But we service approximately 20,000 patients as well. And we do have Spectrum services integrated in our offices for the behavioral health.
I'm Bruce Nesbitt. I'm President and CEO of Spectrum Health and Human Services and President of the Board of Governors for Health Home Partners of Western New York. We serve 5 counties across Western New York, and Erie, Niagara, Wyoming, Genesee, and Orleans with different programs. And we at the same time, through our health home, served 19,000 individuals last year.
Good morning. My name is Ann Constantino. I'm President and CEO of Horizon Health and Horizon Village. We operate out of Erie, Niagara, and Genesee counties. The best way to sum up what we do is we provide services from crisis stabilization, rehabilitation, disease management, and recovery follow-up for people with behavioral health disorders, including mental illness and substance use disorders, and their families. So we serve about 15,000 people every year, and we have inpatient and outpatient services.
So that was quick, thank you. A lot of good questions. I want to start out, and this is probably directed, oh, and Amy and Al, why don't you come up too? You can just kind of squeeze into the table. This is probably best directed at Cassie and Brenda. If you could give examples, and I'm going to add a corollary, but if you could give examples about how the CBOs have been actively engaged with some of this work, and if you want to also talk about any kind of internal changes you had to make in terms of capacity building or anything else to get ready for this work, that would be helpful.
So let's start with the beginning. So we have, our outreach team is actively out in the community, like I stated before. So we have already established ourselves in the community as navigators and resources for connecting people to services. So our outreach team is out at the community centers, senior centers, and BMHAs, and this kind of was a perfect fit because we were already talking to this population. And so with this patient activation measure and this tool, we were able to survey them as well as better figure out how to approach them at their levels of health because we were able to actually gauge where they stood in their healthcare with this tool. We've definitely had to expand our tracking processes because we originally started in mammography. And with primary care, there are a lot more variables that come into play before we could properly and successfully navigate a patient to scheduling services. So it was definitely a learning curve, but we have expanded our tracking to track patients from where we first met them and where we originally recruited them to, and to all of the amount of time it takes to navigate them through their processes between initial contact, actually establishing a location for where they would like to go for primary care, following up to see where they have already been for primary care, trying to see if they are actively enrolled in current health insurance, which was something that we really had to work on, getting connections with facilitator enrollers to get them enrolled in some health insurance before we could get them scheduled for primary care, checking to see if transportation was a barrier, as well as child care and work. So we've really had to expand how we gauge our patients before we could actually navigate them to primary care.
And I would ditto that. I think if I started 90 years ago, we started at a community health worker level. That's what we did. We responded to needs in the community, and we developed a trust and mutual respect with the community. So the work that we're doing now is all mission-based. That's why we exist, to serve the community and to empower them and get them to the resources that are necessary, as I said, for them to enjoy a quality of life. So having community health workers and being a founding member of the Community Health Worker Network in Western New York is very rooted in how we serve the community. And so there's been no change in our culture. We've always tried to make sure we connect people in a way where we meet them where they are and work together to get them to where they need to be. Right now, we have this particular initiative, and we don't call it an initiative. This is part of our business model, is having community health workers who are actually in the clinical settings. In Erie and Niagara County, we're currently in 5 clinics. And it takes an individual who is working within a culture as part of a team to serve the individuals in meeting some of the social determinants of health, in getting them to those services through the Urban Leagues network and through our community partners. And so guess what, folks? After 90 years, we're pretty damn good at it. And it's working effectively, and we're seeing results, and that's what matters. It's not that we serve 20,000 people, it's what is the impact and what is the difference we're making in their lives. And I think it all starts with that relationship and continuing to grow that relationship to see the outcomes that we want to achieve.
Anyone else want to weigh in on that? Those were great. All right, Cassie, you alluded to something. It's a terrific segue. Another question asked, essentially, in terms of tracking, what sorts of systems are in place so that community-based organizations, hospital systems, and particularly primary care physicians can kind of follow the information about patients? So, you know, if someone's released from a mental health facility, something like that, how does the communication flow and how does tracking take place? And that's open to everybody.
Well, I will say one of the things that we've benefited with our relationship with Millennium from is they've provided us a tool called Watchdocs. And Watchdocs is a secure location where we'll be able to transfer patient information once we've established a business associates agreement with that practice. We'll be able to securely transfer patient information as well as for everyone to be on the same page in the reporting processes. And we've actually been developing and talking to a lot of our partners about creating a standardized way for us to track how we are interacting with these patients. Because as Brenda alluded, it is a lot of work to really meet these patients where they are and to really get all of the things that are quality data for reporting. We've had to really expand this between again, like barriers that they're encountering, insurance issues, preference for locations, things as simple as what days of the week work better for you to decrease their chances of no-showing. So we've really had to expand and develop and really think about some of those social determinants of health and how that affects these patients' appointments.
I want to throw it to really particularly Ann, Bruce, Paula, and Brett, too, to talk about the kind of communication and tracking that takes place between the mental health providers and the primary care physicians. So if you have any comments about that.
I guess I'll go first. There are parts of it that are very challenging. One of the most important things that we do is we have subscribe and notify with Healthy Link. So we do find out when our patient has shown up at a hospital, which is very important, and we work closely with the health home providers. The challenge, and I'm sure Bruce can talk a little bit more about this as well, is that our electronic health records and primary care electronic health records do not communicate with each other, and due to some of the regulations governing the information on our side, we have to be very careful about how we share information. So we're continuing to try to improve that system. A lot of it is manual, unfortunately.
I think the same mechanisms that Ann's speaking about, Spectrum utilizes also. With our health home, we do get real-time alerts to the desk of our care coordinators when someone shows up at any ER or is admitted. And for those individuals then who are active with Spectrum, we're able to have that communication in that regard also. The 42 CFR on substance use is a barrier that Ann was speaking about in terms of additional layers of confidentiality. But I know Healthy Link in the first quarter of this coming year is looking at resolving that in terms of how they can get the proper releases to be able to share that information appropriately. So it is a challenge. We are embedded Spectrum in 5 different primary care practices. That clearly opens the door to better communication and coordination, and that's building relationships within practices. Community Partners is supporting 4 of those, 3 in terms of OLV, the Mercy Comprehensive, and now shortly with Lakeshore Primary Care. The other 2 we already have embedded satellite clinics. So it's part and parcel of doing that. We're also working very closely with Latanya and Millennium, where we have health home care coordinators now rotating through 3 months at a time to the ECMC ER, and also now starting over at Buffalo General, working with the physicians and being right on the front line. And again, that helps us then to be aware of who's being admitted, to help divert, and also to follow up then in terms of individuals who are being released with discharge planners and so forth.
In addition to what Bruce and Ann also said, we have the same challenges. We're often just relying on, certain test results that will come over that we recognize come from a hospital. But we also, if we know we're sending a patient to a hospital, we'll set reminders for ourselves to follow up with the patients. I think those are our only means and mechanisms. Healthy Link is a big help.
Yeah, similarly, we, similar to Paula's group, we track admissions, discharge summaries that come from the hospitals. We're in the process of turning on ADT alerts so that we can react more proactively, but we've also engaged in efforts to identify frequent utilizers of the emergency department, and we will send outreach letters saying, hey, we're open from 8 to 8 Monday through Thursday, and we have Saturday hours. We have open access schedules so that you don't have to use the emergency department, and so it's sort of a concerted education campaign that we're engaged in, but ADT alerts will really help us. We're just needing to set up our process on site, and Millennium's kind of been helping us to think about what is an appropriate process, and other entities have figured it out, are a little more ahead of the game than we are, but bringing best practices to bear for us is helpful.
So it sounds like information can flow, and Healthy Link is an important part of that. But in terms of there's a concern that the data doesn't really come together for kind of you're nodding. You see where I'm going with this. Is the lags in terms of baselines and how the metrics, how we're doing against those, there seems to be a lag. Is there any kind of data warehouse or any kind of one-stop shop where all this data that's current comes together that people can look at? I think, Brett, you referred to a little bit of that, some things you look at, but across the region, is there any kind of resource like that folks are able to talk to?
There's something that likely is going to be happening over the course of the next 3 years. Along with Ann, Horizon, Spectrum, Best Self, and Endeavor, we've formed Value Network, LLC, IPA, and we're one of the applicants for some of the $60 million the state is putting forth to build a behavioral health readiness program. Part of what we're going to be doing is building an infrastructure that will work toward essentially connecting all of the different resources in the 8 counties of Western New York. We have right now about 83 organizations that are part of our application to the state that represent virtually close to 100% of all the behavioral health clinic providers and home and community-based services. It includes all the major hospital systems, Millennium, community partners, FLIPS. So that project is going to be geared toward connecting those dots. And if we're successful in our application, which goes in Friday, and we'll know by January, will begin to be funded to build that infrastructure across the 8 counties of Western New York, building on Healthy Link, building on Millennium's population management, what Community Partners has done, but also there's other resources such as Your Care out of Monroe County has put together an MSO where they now are able to have real-time access to all the regional MCO's data, and we're going to be looking to leverage that also.
Now, will that primarily be behavioral health data?
No, it will be both behavioral health and medical data, HEDIS measures, the whole works.
We've purchased Cerner Healthy Intent, which is a population health data analytics platform. We're using obviously the state dollars, the PPS dollars through the district program to do that. It's a data warehouse. It's an analytics tool to do risk stratification. There's a component that's called Healthy Care to help us do care management, care transition stuff. But we're still working through all of the state regulatory hoops to get our Medicaid data flowing through that platform so that it's a tool that the whole region can use. So that's where we are. In the interim, we have Medicaid access portal data from the state called MAP data that we're all using. Us community partners, we're using that data, and we're doing kind of homegrown analytics, if you will, to try to use that data to give us trend information on how we're doing. It's unfortunately, it's not up to date, it's dated. And then we got to do boots on the ground with the individual providers to help them look at their own data, and then we compare their own data to the analytics of what MAP can give us. So that's kind of where we are with the short term and the long range.
I could ditto what Al said. We use the MAP, the salient tools. Again, the most recent claims-based measures are up to February 2017, which is still a significant lag. We do have a population health analytics tool called Crimson that the Catholic Medical Partners primary care practices have been importing both data they get from their managed care contracts, as the claims data they get through their managed care contracts, as well as CCD, continuity of care documentation from the EHRs. I think where they've had the most success is with the med-ent practices. And we are extending those population health analytics tools to our colleagues in the Chautauqua County region who are using med-ent, and we have one other EHR we'll be looking at. So those are opportunities for us to do data aggregation, look at utilization, look at opportunities for creation of targeted registries. All of the safety net primary care practices in our PPS, and I'm going to guess the majority of them in Al's PPS, are working on patient-centered medical home work, and all of the patient-centered medical homes have process enhancements that work off patient registries for key metrics, and do that sort of constantly looking at best practice to sort of communicate with their patients and across different modes of care. So if you're patient-centered medical home, this is definitely part of your everyday workflow. We recognize, though, we can do a better job with mental health handoff, which is what I think Phyllis was speaking to, which is we can incentivize providers to look at different ways to sort of communicate better across primary care and mental and behavioral health services. So hopefully by injecting some resources in and asking for their input on an action plan, we can sort of put some improved Band-Aids on some of these processes that may not be exactly working perfectly, but may be specific to a behavioral health provider and their unique workflow or EHR system until you guys are all on one.
I think one of the exciting things that's going on is what Millennium and community partners are doing, but building on all the work that's being done around data and selecting what's important data and being able to report out on that and look at outcomes, because it's all part and parcel of what's coming and is in terms of value-based reimbursement. And the key here is for things like Value Network and the PPSs and what's going on in terms of the FQACs is to be able to work to make comprehensive and integrated use of that data and make it meaningful. And I think we're on the verge of being able to do that in a more broad-based across the 8 counties of Western New York. So I think that's something that is one of the huge benefits of what's been going on over these last 3 years.
So I think it's obviously a positive that people are focusing on that. I guess one of the concerns, and we've heard this in the community a lot, is if one system has their own population health, if each system has their own population health database, at some level, is there plans to bring those together? Because if there's more than one database, then that's problematic as well. So is that in the works to bring these all together for everybody, because people move from one system to another?
Is there the ability to have behavioral health merged with other systems, I guess would be my question.
Well, we're being held, behavioral health is being held to the standard with the state of looking to focus on wellness and connecting the head to the body. So that, which has never been the case up until recently. And so when we look at things like Value Network, and your question was well taken, it is going to be holistic at looking at, and we have all the major hospital systems, we've got UB Med, we have Catholic Medical Partners, and we're looking to engage all of the primary care in that kind of process, so it does get connected together in terms of head and body.
I guess I just want to say, I think it has been one of the most important areas that we've been working on. So, many of us have used data, and I go way back, so even, hashtags or hash marks on Yellow Legal Pad to try to get your arms around kind of what's going on with your people. There is information available. It's not easy to aggregate it. It's not easy to use it in a real-time workflow. I think that's where, at least for my organization, we have spent a lot of effort, a lot of resources, and are beginning to see the results of that focus on data. We have things called flags and tags, we have reports, we have workflows now around the data. So, you know, I would just say for everybody, I think that that's our challenge, and then as the systemic solutions come, we'll all be better ready to participate and take part in that.
I'd just like to add, I think we're going through a generational evolution here in terms of our data analytics and having a regional data solution. Obviously, Healthy Link is our regional health information, kind of our RIO, of helping pull a lot of that together. But in terms of having one platform for the entire region, I just think we're not there yet. I think it's an evolutionary process. We're in the first generation. I think there's another couple of generations over the next few years that are going to happen. It's going to make that happen. I don't know. We don't know what that looks like. None of us do. But I think it can happen. But we just got to figure it out as we go.
We're going to take a radical shift from data now to something different. So a number of people have talked about social determinants of health. And I hate to say it, but that's almost become a cliche. So can somebody give us a pretty good, concise definition of that, and also maybe segue into what's being done specifically with boots on the ground to address social determinants of health?
I can talk about my definition we use, which is non-medical issues that affect your medical outcomes. That's the simplest way to talk about it.
Social issues
Yep.
that affect health.
Yeah, I think our group, we define it as pretty much what's going on in your everyday life that would affect you from taking care of your health needs. So for us, it's transportation, childcare, work conflicts, insurance, housing. There's just all of these things that come into play before a patient is thinking about attending an appointment. So that's how we kind of define it and how we assess it.
And we use the same definition. It's life, and life happens, and it's almost what you said earlier about connecting the head to the body. People have all of these life issues that definitely impact on their health and well-being. And so it's all of those things that impact us individually and collectively.
I would say
In
cultural and language barriers are a big portion of the barriers that we encounter, and we try to help our patients navigate through, because there's not very many Karenni-speaking gastroenterologists out there. So we've got to help folks navigate stuff like that.
Are there any specific projects or programs underway that address things like, and we've heard about transportation forever, and at least 2 or 3 times here today. So any specific programs addressing housing, transportation, things like access to healthy food, even education? These are all some of the things. What specifically is being done in those areas?
Well, for the National Witness Project, when we set up patients for primary care and dental appointments, we do provide transportation for that initial appointment, as long as it's within a certain radius, but we try to alleviate that barrier. We offer transportation services at no cost to them, not through Medicaid services, for us to be able to provide them that, to reduce their chances of missing that appointment. And then we also provide health education. So we do breast and cervical cancer education as well as colorectal cancer education. And we also host community conversation forums where we're actually just reaching out to the community, meeting with them, and kind of assessing what they feel about primary care as well as scheduling appointments for themselves.
We do likewise. We're there to facilitate their connection with their health and health needs, both in terms of prevention as well as taking care of just, those unfortunately chronic conditions that many people are plagued with. But it's everything from making sure if transportation is the issue or challenge they're facing, making sure that we have people who can pick them up and take them to the appointment and help them get to a point where they can make that navigation themselves. Primary care is a huge issue. It's been articulated as one of the areas that we have to work on in this community, connecting them to a primary care, empowering them to understand you should be selecting a primary care provider, just like you select anything else in your life. Helping people to, again, appreciate that they have choices. You don't have to go to the doctor that's pre-assigned and you never went to him or her, and you don't even know where they are because it's not in your neighborhood or in your community. So giving people the education and the tools, and we do that in one-on-ones and in group settings with all of our population that we directly contact and with the community as a whole. And so we do offer workshops in diabetes prevention and management. We are not healthcare providers, but we are community educators and can provide them information. We teach them about healthy living and how to manage and control through diet and exercise. And we reinforce that in not only our, quote, health space, it's in our family preservation and support space. So it's dealing with the whole person, and it's using it to integrate with our housing programs. You know, when we have to have a family move because the child has asthma, because the house has mold, you know, it's all of those things that, as we said, they're life issues that people are addressing that are connected to their health and well-being, whether it's physical, mental, or emotional health.
I guess what I want to say about transportation is I think it's important that we look at any creative opportunities that we have to minimize the impact of a poor transportation system. That being said, people, to have quality of life, you need to be able to not be isolated, to participate in the community, to have freedom and opportunities that may be in other neighborhoods. So, while I know that we all are working on every possible way that we can to connect people who have transportation challenges, I think it's a huge regional issue that needs to be improved for the overall quality of life in Western New York.
I'll just add that Spectrum was one of 13 agencies, behavioral health agencies in the state selected to be a federally certified community behavioral health clinic program, one of 70 in the country. And it's a demonstration project through SAMHSA, but it allows us to provide all of our services anywhere in the community outside the four walls of our clinics. So we're no longer limited as of July 1 to serving people with behavioral health needs within licensed clinic walls. So we're also funded for peers and case managers. We have nursing staff at all of our sites. So it's the future of clinic services, and we're very happy to be able to be part of that, but it also allows us to overcome some of the barriers to transportation by providing services in the home.
For us, it's been really helpful to bring outsiders to the inside, and by that I mean hiring people from our communities who speak the same language as the patients that we serve, who live in the same communities as the patients we serve, who can translate the complicated healthcare system we have to those who it might be foreign to. So if you come to our Genesee Street office, you might see Yvette at the front desk, who lives down the street and kind of knows what it's like to live in that neighborhood. And so trying to help, to being very committed and intentional about hiring people from our community, it both serves as a community development exercise, but it also makes us accessible to people who would be intimidated by talking to a PhD or an MD about an issue. If they might tell their interpreter something that they would never tell some of us. And so having those folks empowered to inform what we do, be engaged in giving us feedback about what our patients are experiencing, and they're not just interpreters or community health workers. They tell us, you wouldn't ask that question of our community. Here's how you ask that question. And so investing in our community resources and having them be so important to the quality of care we deliver has been one of our biggest commitments, and it's kind of happened organically, and we're really blessed to be in a position like that, where we're partnering with our community to serve our community.
And understanding the cultures in the community and people's value system is critical. And as I said, we built a relationship of trust and mutual respect. It's not a judgmental approach, and so there's no one more important than the person we're serving. And that's our organizational culture. And so whether you walk into the Urban League, our young people, many of whom who haven't graduated from high school, may have been formerly incarcerated, you know what, when I walk in the door, they know who I am, I'm approachable, and everyone in our organization feels the same way about them. We respect them, they trust us, and guess what? That's why they tell us they come there. And so sometimes people don't take care of their health needs because they don't feel comfortable. They feel a separation. And doctors want to care for patients and they want to prevent diseases, but they don't have that relationship of comfort with them and trust and respect. And so we work very hard to make sure that in everything we do, we underscore what you're saying, Brett.
So the people in the organizations at this panel, and I'm assuming a lot of you kind of get this, and I think, you know, we all want to say that we're doing a good job of meeting patients and people where they are. But in terms of systems, to make this work sustainable and really, really meaningful for a huge population, what sorts of work is being done to engage with systems leaders, whether it's education, transportation, housing, so that, again, those systems, the policies that really hit people where they live and affect their behaviors, how are those leaders getting engaged?
One of the wonderful things about the Urban League is it's part of a national movement, and so we have an opportunity to work on policies at the national level and also at the state level. And so we just happened to be, and I'm saying we, Grace Tate and I, at a meeting last week in New Orleans, and we had sessions with the American Hospital Association. And guess what? They're very concerned with the future of care within the hospital systems, as we are locally, and about how do we reach people. And as an outgrowth of that meeting, we were able to share with them some successes and best practices around how those systems can better respond in terms of board level policies within their institutions, as well as at the community level. And in fact, as an outgrowth of that, Grace is leaving tomorrow to go to a conference that the American Hospital Association is sponsoring that is really focused on community health workers. So they get that they have to connect with the community at the grassroots level in order to impact on their health and wellness. And so I think at the policy level, we were able to give them, and it can't be a one-time thing. It's got to be an ongoing process to integrate. But I'm going to tell you, it's happening across the country. It's happening now. And I think it's great that we're all moving in the same direction.
You know, this the social determinant of health tagline is just, you know, a new phrase. This is work that social workers have been doing for ages. I mean, this is nothing new. And, you know, we have these people in the community, the social workers, who are so incredibly valuable, who have been doing this work for us forever. And those are people, you know, we're talking about getting together with the discharge planners, which I think is awesome because they're critical on helping us close these gaps. But I think the social workers are other people that we need to get in a room and get at the table. They are the folks that know the answers about what services are available and where, and to get them all together to share their resources, I think would be a critical thing to do as well. Where is there available transportation? Let them share where is housing available, and for what subset of people, for what income level, you know, where they're finding the best help for substance abuse, et cetera. You know, and then, you know, as far as leadership, I mean, that's a whole different story with politics, et cetera. I don't know how we break through those barriers, but I think getting these folks at the table is important.
And I want to address, I think it is the responsibility of all of us to have a relationship with our leaders and our legislators, and to educate them regarding what's happening in our communities and for the people that we serve. I know I spend a lot of time, both at the local, state, and even national level, being very active, as active as I can be. I'd like to be way more active because I have a lot to say about politics. But it's a little editorial comment. It is the 8th of November. You know, I think it's very important, and we have seen local success with our legislative representatives, particularly around the opioid, problem, and certainly around mental illness. I think we're lucky to have people who are open to the conversation, but we have to keep the dialogue going and the pressure on and keep talking about what we need to deliver resources to our community. Because, the other thing that happens in New York State is resources tend to go downstate. They don't come our way. So I think the more active we are, the better it is. And I know Bruce is also active in the same organizations I am. This year, I'm going to train people in my organization on advocacy. We're just going to do a formal training, and we need an army really doing advocacy.
We're fortunate here in Western New York that we have a high concentration of behavioral health leaders who are working at a local, state, and national level. Between Ann and myself and Howard Hitzel and Liz Morrow, we all hold positions of board membership at different levels across the state and beyond. So I think that's part, it's only a piece of, but it's part of what we feel a responsibility that we should be doing.
I would just also think, as we connect the former question about social determinants, when we look at health, we need to look at it very broadly, because the number one issue that we hear, we do workforce, we train, as well as help people not only gain employment but retain employment, is that employers are, they can't find individuals, and one of the number one reason is they fail drug tests. So when we think about that in terms of how do we approach the leadership and get them actively engaged in creating systems in our community that keep people healthy, it's an economic imperative, because if companies can't find workers because people cannot pass drug tests, and there's plenty of people who can, but that is a major concern. It's the number one issue I hear about constantly. Then we have to think about health and using the leadership in a broader way than in our individual silos. We've got to connect it to economic opportunities in our community, because if you can't get a job, then you're going to have poor housing, you're going to not have access to medical services, good quality food, you're not going to be able to, enjoy a quality of life as we're talking about. And that's really the broad opportunity that we have to now utilize those other systems and those other leaders that actually have a tremendous amount of influence to people who make policy, particularly at the state and local level. So I just want to make sure I throw that out for free.
Let me apologize. No, we're not going to get to all the questions. I'm trying to kind of make it flow and segue one off the other. So I'm going to pick up Brenda. You talked a little bit about workforce, and in terms of the workforce in the healthcare system, talk a little bit with the system changing so much. What sorts of things? What's the shift? What are the changes in terms of the type of people you're going to be hiring, and how actively have I guess the healthcare community? How actively have you been engaging with the institutions of higher learning in Western New York to get ready for that?
As part of DISRIP, we have a workforce component. We have a workforce subcommittee of labor and the various human resource leaders at the various provider levels. The biggest thing we're seeing through the data, because we collect a lot of data for DISRIP to report to the state, workforce surveys, compensation and benefit surveys, we're doing all that stuff. So there's a shift to more licensed practical nurses, LPNs, medical assistants, community health workers, those types of of jobs. That's what there's going to be an increase in. And so that registered nurses and physicians and nurse practitioners and PAs, they can all work at the top of their license. That's the move. What we're seeing right now is more as workflows and job descriptions are changing with what we're doing in DSRIP. There's definitely going to be some changes in the way work is done. We're already seeing some of that. So, we're just in the beginning stages of seeing the workforce changes happen as a result of where things are going. So that's my view on it. So.
And is there some collaboration with the area colleges and universities to kind of get ready for that?
Yes.
So, okay, good.
Yes,
Perfect.
absolutely.
I happen to sit on the Regional Economic Development Council, and we created a plan for the region. And one of the sectors that was identified as a growth sector is health and life sciences. And so we've been very focused on, many of you have heard about the governor's Buffalo Billion and the $1.2 billion, on making sure that we have both a pipeline that is prepared for those careers in the health sectors, but also that we provide an opportunity for people to be upgraded, learn, and continue to grow is part of a career pathway. One of the challenges, really, very frankly, is when you talk to people about healthcare, many times, and I'm talking about really at the grassroots level, most of their knowledge is about nursing assistants and possibly LPNs. Mm-hmm. And so we think a large part of what we do and what we're encouraging community providers to do is to have relationships with our healthcare community, to expose and educate our community about careers in healthcare. And the reason I use the word careers is I want people to continue that learning process and be able to get to a point where they have the economic self-sufficiency that many times individuals who are nursing assistants frankly don't have. So we're looking at it from a pipeline as well as using tools with higher education, with our partners in higher education, and with some of our partners who are doing workforce training to provide opportunities for people to access those career ladders. So taking young people on trips, taking their parents on trips to our medical campus. They hear about the jobs. That community surrounding the medical campus is primarily a low-income community. I'm talking about the side on the east side, the Fruit Belt. People walk by those places, and some of them work there, but they really don't understand the full gamut of opportunities. So I think we have a lot of work to do, because guess what? As I go across the country, every community is saying, healthcare, advanced manufacturing, travel and tourism. We all have the same industry sectors as a country that we're focused on, and if we don't grow our own people here, we're going to be competing and probably not be able to continue to grow the kinds of systems that we need as a community and really increase the economic opportunities for people in the community, which generally the connection between economics and health is pretty profound.
So a couple of comments from the community-based system perspective. Our system is currently underfunded, and even people with master's degrees and licenses do not get paid equitably to their responsibility and the pressure of that type of position. So while that's great, if we don't do a better job bringing those economic rewards to careers in healthcare, then we're going to continue to see the best and the brightest either leave, take the jobs at the highest levels of the health sciences, and if we want people to get better at the community level, then we have to invest in that workforce. And I'm going to tell you right now, with rates that are based on 8 to 10 years ago costs and increasing responsibility and duties, that's the revenue that pays the expense. So the numbers don't work. It's a problem.
think we have time for one more question, but before we do that, there are a lot of specific questions directed really at Millennium and community partners, and we're not going to get to them all. So I want to do this. You see, obviously, Amy and Al up here. If you work for either community partners or Millennium, please just stand up, please. Because I want to give people an opportunity to hound you after this, and you know, you can swap business cards or do whatever you need to do to follow up, because I want to make sure people, again, there are a lot of really, really good questions we didn't get answered. So find your target if you have a question, and go grab him or her after this. The last question is really kind of a sum up. So when Amy and Al presented, there were about 12,472 different data points that they presented. but what we'd love to see is really just give us two numbers for each of you, if you could, please. Just talk about what's the percentage, tell us, however you frame it, what sorts of impacts have you made in terms of ER utilization and hospitalization? Because, again, that seems to be the bottom line for you. So understanding that the data's lagged and all those other things, people would just kind of like to hear those two kind of high-level bullet points. So that would be helpful if you could.
From community partners' perspective, we're doing well on the readmissions. So
Okay.
we're continuing to have a positive trend, meaning reduction. And then on the potentially preventable emergency room visits, we've got a lot of work to do. That's fluctuating. That's going up and down. So from our perspective, and it depends on which hospital you look at. So it's highly specific to the hospital, and it is measured at the hospital level, and it's a claims-based measure. So, but we're seeing it do this. So yeah, there's more work to do in consistency on the ER visits.
Is that a technical term?
Yeah.
All right.
Yeah, ditto what Amy said. No, honestly, I wish I could give you the number on preventable readmissions. I'm looking at both Christine and Michelle. Is there a number? I know we're doing better. We were doing okay on preventable readmissions, like Amy said, in measurement year 2, and we're definitely doing better in measurement year 3. Is there a number? I know Christine looks at this stuff in terms of number of patients and that kind of thing. Is there anything you want to toss out, Christine?
I don't have a number memorized. I will say that we performed so well in measurement year 2 that the target was reset at a very aggressive level. So although we continue to improve and perform well in comparison to New York State averages, we are struggling to hit this very aggressive target in our readmission reduction. Preventable emergency room visits continues to be a problem and continues to actually climb in some ways, despite our best efforts, but we've launched a lot of aggressive programs to try to address that.
Okay, so it's fair to say there's some good progress in certain areas,
Yeah.
some work to do in others, but overall the trends are good, so that you're having some positive impact in the community. Is that a fair characterization?
Yes, and I do think that unfortunately these data, when you're collecting it at any one point in time, it is going to fluctuate. So.
Terrific. So that is all we have. We are just about out of time. So I'd like to ask everybody to join and thank the panel. Terrific Gary Cannon conversation. Thanks as well to Andrea and Phyllis, who presented earlier. So one last comment. We are doing evaluations on this. So we're open to all sorts of ways to have the PPSs report out to the community. So as you do the evaluation, please keep in mind what might work best for this. If you like it like this with a live conference and different people, please, we'd like to hear from you. We are more than happy to kind of tweak what we do or overly, dramatically change what we do to make sure that you're getting what you need. So please do the evaluations and be very, very candid with your input. So thank you all for coming. Have a good day. Good job. That was good. That was good. Yeah, that
It was a lot of
actually went on.
content.
It was a lot of content.